Hi, my name is Lisa Chirch. I am an infectious diseases physician and faculty member at the University of Connecticut. In this video, I will provide an update on HIV therapeutics and also review new guideline updates. Nearly 40 years have passed since initial reports of unusual clusterings of pneumocystis, candidiasis, and Kaposi sarcoma in New York and California were published in the New England Journal of Medicine and the MMWR in 1981. The years that followed witnessed the discovery of a novel retrovirus as the infectious agent of this newly identified acquired immunodeficiency. The slow and arduous process of drug discovery ensued over the following decades. It has taken many years, but the availability of better tolerated and easily administered antiretroviral therapy now allows people infected with HIV to live near normal lifespans with well-controlled infection. This Associated Press article published earlier this year highlights a recent CDC report suggesting the number of new HIV infections has failed to drop, remaining steady over the past few years. Of the more than 38,000 new HIV infections documented in the United States in 2016, nearly 20,000 happened in the southern United States, more than the combined total for the rest of the country. New infections have been dropping among some groups, including African American women, those younger than 24, and gay white men, but continue to rise among certain demographics, such as young African American and Latino gay men. That number grew 65% from 2010 to 2016, offsetting decreases in other groups. Shifting gears briefly to HIV virology, which is important to remember when considering the mechanisms of antiretroviral agents. HIV is a lentivirus in the group of retroviruses because it causes slow infection with a long incubation period. The HIV genome contains 3 structural genes: GAG, POL, and ENV, and 6 regulatory genes. The GAG gene encodes the internal or core protein such as P24, which is important because it is the antigen used for 4th-generation testing. POL encodes reverse transcriptase, which is important for transcribing RNA into DNA, integrase, which integrates viral DNA into host DNA, and protease, which cleaves viral precursor proteins before the virus leaves the cell. Each of these enzymes is an important drug target for HIV therapy. Finally, the ENV gene encodes GP120 and GP41, which mediate the attachment of the virus to the host cell. The first step in the replication cycle is the binding of GP120 envelope protein to the CD4 receptor. GP120 also needs to interact with a second protein on the cell surface called a chemokine receptor. You can see CCR5 here, but another important chemokine receptor is CXCR4. Mutations in CCR5 confer protection against HIV infection. Maraviroc, shown here, is the CCR5 inhibitor active at this stage of the cycle for certain patients. The second step occurs in the cytoplasm. Here, reverse transcriptase transcribes viral RNA into double-stranded DNA. Both the nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors are active here, and some examples of these drugs are listed in purple. The double-stranded DNA then migrates into the nucleus where it integrates into host DNA. This integration is mediated by the enzyme integrase. Enter the integrase inhibitors. 2 are listed here. The next step is the transcription of viral messenger RNA by host RNA polymerase and then translation into large polyproteins. These need to be cleaved into small viral proteins by protease, which is where protease inhibitors are active, and 2 examples are listed. It is this cleavage of polyproteins that results in mature infectious virion, which then exits the cell. These 2 photos tell the story of how far we've come in the past 20 or so years in terms of drug discovery, allowing a majority of patients to effectively control their HIV by taking 1 pill a day. Here is a list of currently available antiretroviral agents by class And on the right, you can see the available fixed-dose combinations, many of which represent a fully active regimen in one pill. What regimens are recommended to start up front in naive or newly diagnosed patients? Both the International AIDS Society and the Department of Health and Human Services frequently update their guidelines. And here you see the most recent iteration of what to start according to the DHHS. Note that each first-line regimen contains 2 NRTIs and 1 integrase inhibitor. So protease inhibitors and NNRTIs are no longer considered first line. 2 of these 4 regimens here are one-pill regimens. Note that regimens containing L-Vitegravir cobicistat are not listed and are now recommended only in certain clinical circumstances. Cobicistat, a pharmacoenhancer, greatly increases the likelihood of drug-drug interactions. Guideline recommendations as to when to start antiretroviral therapy have evolved significantly over the years. Many years ago, the idea was to wait as long as possible to start therapy in order to avoid considerable toxicity secondary to the medications. So, for example, several years ago, we may have waited until a patient's CD4 count dropped below 350 or even lower to start therapy. This has changed dramatically in recent years, based on data from large observational cohort studies and later a randomized controlled clinical trial, which I'll review in a moment, showing that patients who wait to start therapy do significantly less well on many levels. This quote from Chuck Hicks in 2013 highlights the current thinking. He writes in part, "When HIV is allowed to replicate uninhibited by ART, resultant immune activation and inflammation are associated not only with immune destruction and opportunistic infections, but also increased rates of cardiovascular, renal, hepatic, and neurologic diseases, malignancies, and other serious non-AIDS diseases." These are the results of the START trial, published in 2015, which randomized people with CD4 counts above 500 to either start therapy immediately or wait until their CD4 was below 350. As you may know, the Data Safety and Monitoring Board recommended that the results be immediately released when they identified a 53% reduction in serious illness or death with immediate ART. This is one of the figures from the article depicting Kaplan-Meier estimates of the cumulative percentages of patients with the composite primary endpoint in the 2 study groups. You can see here that there was a significantly lower risk in patients who started ART immediately, represented by the red bar. Next, I'll review a few important updates to the guidelines, starting with 2 drug regimens. The use of 2 drug regimens when starting or switching therapy is an area of much interest. Fixed-dose combination dolutegravir-rilpivirine, an integrase inhibitor plus an NNRTI, was recently approved for suppressed patients with no history of treatment failure or resistance. This is particularly useful for patients who cannot tolerate NRTIs. The NRTI lamivudine is being looked at in combination with several different protease inhibitors, so far with favorable results. Lamivudine is also being studied in combination with dolutegravir in the ASPIRE trial, a randomized open-label multi-center phase 3 trial in which suppressed patients with no history of failure switched to this regimen. At week 48, 91 versus 89% of patients were suppressed with similar rates of serious adverse effects. The LATE-2 trial is an open-label multi-center phase 2b study comparing continuation of oral cabotegravir, an investigational integrase inhibitor, plus abacavir lamivudine versus switching to intramuscular injections of cabotegravir plus rilpivirine every 4 or 8 weeks after an oral induction phase. 96-week results show 94% suppression in the every 8-week injection arm, 87% suppression in the every 4-week injection arm, and 84% suppression in the oral 3-drug daily regimen arm. So these data are quite promising. Another recent guideline update highlights safety concerns related to the use of dolutegravir in early pregnancy, specifically neural tube defects. Data was presented at the AIDS 2018 meeting and a correspondence published in the New England Journal describing the prospective cohort of pregnant women in Botswana, in which investigators were looking at the relationship between antiretroviral therapy and neural tube defects. The figure is from the New England Journal article, showing preliminary data suggesting a nearly 10 times higher risk of neural tube defect when dolutegravir was given at the time of conception. With additional accumulation of data, the risk was reduced somewhat from 0.94 to 0.67, but was still higher than that seen with other drugs or when dolutegravir was given later in pregnancy. This cohort is still being tracked, so stay tuned. For now, the consensus is, in early pregnancy, probably don't use dolutegravir. Lastly, let's discuss a brief update to the opportunistic infection guidelines related to MAC prophylaxis. This updated recommendation is based on data from recent observational cohort studies reporting extremely low risk of disseminated Mycobacterium avium complex disease in patients with CD4 counts less than 50 who are virologically suppressed. This slide summarizes the new recommendations. Primary prophylaxis is not recommended for patients who start ART immediately. Consider prophylaxis if patients are not on suppressive ART and have CD4 counts less than 50. The recommended regimens for prophylaxis are the same as before. Prophylaxis can be reasonably discontinued when ART is initiated. So this represents a significant change to those guidelines. In terms of the antiretroviral pipeline, we have a few drugs listed on the left. Ibolizumab is an entry inhibitor, monoclonal antibody that binds to CD4 and is being studied for treatment and prevention. This drug was actually approved in the relatively recent past for salvage therapy based on a single-arm, multi-center clinical trial that enrolled 40 heavily ART-experienced participants who had multi-drug-resistant virus and who were failing their regimen. Subjects received intravenous infusions of ibolizumab every 2 weeks, in addition to an optimized background regimen that included at least one other agent to which the subject's virus was susceptible. 27 participants continued on to the 48-week follow-up study, at which point 59% and 63% had viral loads of less than 50 or less than 200, respectively. Fostemsavir is an entry attachment inhibitor that binds to GP120. The BRIGHT study is an ongoing phase 3 trial looking at fostemsavir for salvage therapy with optimized background regimen, with some quite positive preliminary results. Cabotegravir is an investigational integrase inhibitor. Cabotegravir can be administered orally or as a long-acting subcutaneous or intramuscular injection, as previously discussed. Cabotegravir is also being studied for prevention. To summarize, the HIV epidemic in the U.S. is ongoing, and there is still much work to be done. ART is recommended for all HIV-infected patients. Regimens are simpler, more effective, and better tolerated than ever. Guidelines are regularly updated, so keep checking. And new agents and treatment modalities have arrived and are coming for HIV. Thank you for your attention, and I hope this video was helpful.